Thank you, Rebecca. And now I'd like to introduce our invited speaker for today's assembly, Bret Barker, RN MSN. He'll be talking to us on the timely and important topic of chemical dependency and the health professional. Bret is an intensive care nurse with many years of experience in critical care. He also teaches theory and clinical nursing at Gavilan College, and he is beginning work on a Doctor of Nursing program this summer. Bret has taken one of his precious days off today in order to be with us, and so let's give him a warm welcome.
Thank you so much. Good afternoon, the Anza College Nursing Program. It's an honor to be here, it truly is. Thank you, Rebecca, for inviting me to come up here. So this may not be what you think, and that's cool. So we're just going to get right into it. So again, my name, my introduction. I have a long history of chemical dependency in my life. I started very young. So not only do I have hours and hours and hours of research and education in chemical dependency, I have experience before I learned any of that stuff. So I'm going to share a little bit of that with you real quick. So next slide, please. So here's a prediction. Miss, true or false? Drugs are bad. Show of hands. Not me. Okay. Denial is a poor coping mechanism. Anybody? Okay, a few hands. More than that first one. Knowledge can protect you from addiction. There's a few more about the same. Okay, next slide, please. Okay, false, false, false. Drugs do what they're intended to do. Okay, if you give amphetamine to a child with ADHD, it works. If you give antibiotics to somebody, it cures their infection. What the addict does with drugs can be bad. What we do with antibiotics, for instance, if we give too many to somebody, we can cause C. diff. That can be bad. So, drugs work. That's what we do with them, whether it's an addict, a doctor, whatever. Denial is a double-edged sword. Okay? We can't drive down the freeway at 80 miles an hour in a tin can with people passing by us without tuning out and having some denial that that's not happening. Otherwise, we'd flip out and go off the road. We can't take a baby and put a needle in its arm and watch it scream and cry to give it a vaccination unless we put away some of our own humanity and our own denial in order to do that. You with me? Okay, so we're opening our minds here, okay? Open mind, that's what we want to talk about. And knowledge can protect you from addiction. Well, self-knowledge has availed us nothing. There's the most popular 12-step program in the planet that was developed in the 1930s that uses this in its book. And it's very, very true. So it takes more than self-knowledge to be able to do that. So what we're going to talk about is how we can get some self-knowledge. We're going to give you some of that today as a little help. Okay. Next slide, please. So patterns of drug use are pretty basic. They start with experimental, short-term use with friends. They may progress to social, recreational. You go out for drinks with your friends, or social drug use. Circumstantial situation, whether it be self-limited use, like I had a hard day at work, I want to go home and have a glass of wine. Make sure you tell yourself that is self-medicating. I'm not saying it's a bad thing, but it is self-medicating. Okay? Whether you take a Benadryl to go to sleep at night or a cup of coffee in the morning to wake up, we're self-medicating. Okay? If we call it what it is, we have less chance of denial creeping in and attacking us. You follow me? Cool. Intensified leads to that chronic use. I can't do anything without my coffee. I can't go to sleep without a Benadryl or an Ambien. Okay? That's a chronic use. Leading to the compulsive, frequent, and intense use, whether it's crack cocaine, methamphetamine, opiates, okay, which you might see a lot in our profession. A lot of people getting addicted to opiates, and a lot of benzodiazepines such as Ativan and Versed because they work really, really good. Okay. You don't see anybody running around pimping and selling antibiotics on the street corner, do you? Well, I do have a joke for you. You know how you get your patients to take all the antibiotics? You just slip a little bit of methamphetamine and they'll take them all. All right, don't do it. Don't do it. Next slide, please. Okay, so dopamine, they call it the drug of addiction, but really it is the drug of the pleasure reward center. It gets us to repeat things. It gets us to do things. It gets us to mate. If it didn't feel good, we're not going to do it again. Okay? So, dopamine is triggered in our brain by a lot of different mechanisms, whether it's sex, food, drugs, rock and roll. And it gets us to do those things again. If we like something, the dopamine goes on, sends a signal across, we repeat. Next slide, please. Stress and alcoholism talks right about what we just hit. Okay? A lot of alcoholics start out not saying, I'm going to go become a gutter drunk today. Okay, they start with some form, some relief. They take that first drink and they say, I feel better. And then they have another drink and another drink. And the next thing you know, not intentionally, they may be having 1, 2, 3 drinks a day. And that can progress if they're using that as the only coping mechanism. Follow me? Without healthier coping behaviors, they may turn into alcoholics, or they may do something totally different, like buy too many shoes, or work 120 hours a week. Okay? It's the same behavior, the underlying behavior. Ineffective coping mechanisms. What we're talking about today is using chemicals to do that. Okay? At first, reward circuits are able to return to normal. Okay, we fire a little dopamine out, we feel better, we come back to normal, we go about our daily business. After a period of time, as with anything else, we build up a tolerance to things, and we need to rely on those. Okay? Repeated exposure leaves our brain in a state of physiological stress, that prevents our recovery time. Okay? We're always way too tired. It's like being in basic training for 86 weeks instead of 8 weeks. You're just too far gone. Okay, you need to really back off. This is why we put them on residential treatment for 30, 60, 90 days so they can recover physically, physiologically. The spiral of dependence growth is alcohol actually creates more stress. Alcohol is an astringent, it's a solvent, it's dehydrating, it has a lot of calories, about 190 calories per ounce, so you don't really need to eat that much, and this is the problem. It's very, very stressful on the body. Next slide, please. So David Pressey, a PhD, done a lot of talks over at Berkeley. His theories on addiction are the reward levels in the nucleus accumbens on the brain, which is that first slide we saw. It's right there in the middle at the top of your midbrain behind the pons. If you look at this, the scale of number when you eat something and you eat that donut, you may even put out 150 units of dopamine. Okay, picture those as little water balloons going across and hitting the receptor. Splat. Big smiley face, right? 150 of them. Splat. Big smiley face. Sex, about 200. Drag out cigarettes, about 2.25. Morphine's about 200. Cocaine, 350. Well, here's the problem with methamphetamine. Look at that number. Okay? You're going to wear out the barrel of that water balloon gun real quick. And you actually develop holes in your brain. That's why addicts with meth take so long to recover. About 18 months to 3 years just to get back to a physiological normal, if that's even possible, just to start to heal. Okay? And when you smoke something, it gets into your system a lot faster than even the IV drug use. Okay? Because you're going into that huge vascular bed just now. Okay. Next slide, please. So abuse potential, one, stimulants, because it's such a huge amount of dopamine release like you saw. Then next are the opiates, because we have our own natural endorphins. Okay? We feel good, we have our own pain-fighting mechanisms in our brain. Our brain creates chemicals that allows us to ward that off. Otherwise, people would not be having childbirth, right? Alcohol, marijuana, number 3, followed by hallucinogens. Next slide. Now, the theories of addiction. The drugs are ultimately going to tell you that you need to take them in order to survive. Okay, just like with the coffee in the morning. I gotta have my caffeine in the morning. If I don't have the caffeine in the morning, I can't function. And that's also true to a certain extent because you build a physical dependence on it. Okay? The vasoconstriction is enough that if you don't have the coffee, you have vasodilation in your brain and you get a headache. Okay? So there is some addiction to that. Okay? So it's very, very true. Knowing what that is will allow you to cope with that. So taper off your caffeine just like you taper off your steroids and your benzodiazepines, okay? So repeated use of drugs and alcohol saturates that reward pathway. Okay? It's just used to having it. You take it away, you have physiological stress, and you do things you would not normally do. You do behaviors that are not in your character and not the way your mom and dad raised you. Okay? Because you want some more, and you're going to get it from wherever you're going to get it. A person becomes conditioned to those intense levels of stimulation, which leads to another problem. The normal levels of natural rewards are no longer pleasurable. A donut doesn't taste as good as it used to. The drug's fine. Higher doses of the drug or the alcohol. That steak doesn't taste as good. She's not as pretty. Okay? So, after chronic use, that reward pathway gets depleted, so nothing's pleasurable, not even the drugs. If you go to 12-step meetings, you'll hear addicts in there talk about, it didn't work for me anymore. And you say, how could that be? And that's exactly what we're talking about. It stopped working. They needed it to maintain, but they weren't getting high anymore. You follow me? Okay. Which is the problem, because again, why do we put people in long-term residential? They need time to come off this stuff, just to get back to some state of normal, to start to heal. Okay. Next slide, please. All right, I'm going to let you read this. I did give Rebecca this PowerPoint slide presentation so you can all get it and print it for yourself and look at it. I have more in-depth ones and we do more, but this is a kind of a quick primer for you. So what are the factors in the healthcare setting which increase your risk of addiction? They're right there on the board. These factors, such as expected to be the caretaker, you have abnormal working hours and shifts. I'm a 12-hour night shift ICU nurse. Think I get stressed out? Every time they call me to come in, I had to learn how to ignore that phone. I did, because I'd kill myself. I would go every shift, I'd work over, I'd be the people pleaser. A lot of codependency right here. Okay? Sacrifice family time, honey, I gotta go to work, they need me. Guess what? Every single time they call me and they found somebody. You know, sometimes I go in. You know, I like Christmas, I like buying stuff, but not to kill myself. Hard physical work, difficult mental work, you have an element of being in control. Okay, once you get over giving that first injection, first blood, you're going to get like you feel in control. When you're looking at the monitor and everything you do sends the patient in the right direction, you're going to feel like you're in control. You're going to have this little God feeling in the back of your head. Okay, you can keep that to yourselves, but you're going to feel it. Just know that that's it. That's that denial working on the positive side, which can come back and bite you. You have little emotional support. Okay, we're all supposed to be professionals. We stand around, we do our work, it's for the patient. We don't show them that we're feeling sad or glad or happy. We're there to help them. That's it. Right? What do we get at home? Well, unless you're working and living with somebody or married to somebody who's in the healthcare profession, they may not understand you or what you're going through. So at the end of this, I'm going to talk about the We Care support group for chemically dependent healthcare professionals, and that's a place where healthcare professionals can talk about those things. So get some friends and keep them with you, whether you work with them or not, somebody to talk to. Just like you do in nursing school. Please start now if you haven't already. You have to constantly update your skills. You know, whether it's basic life support, TNCC, advanced certifications of critical care nurse, emergency room nurse. Things are constantly changing in healthcare. You have a lack of recognition. You're supposed to do it. And you're supposed to do it perfectly. You have to work with difficult patients. Okay? If you ever dealt with a patient with hypoxia yet? Anybody? Okay, somebody with hypoxia, they go loony. It's not their fault. You have somebody in alcohol detoxification. Okay? Their brain's going crazy because all those depressant alcohol molecules aren't in there to keep the brain activity down. Okay, we have to work with them. We have to understand what's going on with these patients, but it's stressful on us. We want to take it personal, and it takes time and experience to reduce that. And easy accessibility of drugs. I don't care what kind of system they have in place, you can get it. Don't do it. Don't do it. They're easily accessible, whether you believe so or not. And there's an acceptance on some level of the right to self-diagnose and self-medicate. I worked 60 hours this week. I deserve that glass of vodka. Well, maybe a little one, not that big glass of vodka. Next slide, please. So, factors in you that increase your risk for addiction. Am I going too fast? No. Okay. All right, I know you're all sharp. You're all going to be nurses, so you got to be sharp, or you wouldn't be here. So we place our needs before others. Okay, anybody? That's a good thing, right? Yeah. Right? Okay, we're all agreed. I'm not saying any of these things are bad. Just know that these are risk factors. Just being who we are, doing what we do, puts us at risk. Okay. We use denial in the work setting, like I illustrated with the baby with the needle. And 18% of health professionals are heavy drinkers. Use alcohol to relieve job stress. hey, long shift in the ER, let's go over to, TGI Fridays and have a couple drinks, woo. Self-medicating, nothing wrong with that. Everybody has the right to make their own decisions. Just call it what it is. A lot of us come from alcoholic backgrounds. We learn that caretaker role very early. Okay. Spouse is commonly alcoholic. Unemployed women as a group have a higher rate of alcoholism. Okay. It just happens to be statistics and facts that they came more into the health profession and more degraded still, even in the nursing profession, even since the 60s. So we're still behind the power curve on that. We're nurses as givers of care, not receivers. We want to be perfectionists, for sure. We want to get it right, because anything we do can kill somebody. Or have long-standing effects that are not very good. And we believe, again, that our knowledge of pharmacology will give us some sort of protection. Oh, I know I can take 2 milligrams of Versed and I'll be good in 20 minutes after my break. No problem. Yeah. Happens more than you would like to think. Believe me. Okay, next slide. So denial of the problem. Okay. So we all must learn to employ denial or self-deception in order to work with the sick and dying. Covered that. We tell ourselves we're not tired when we haven't slept enough. We go get another latte, another cup of coffee. I love energy shots and Red Bull. I do. I need it. I need to tell my brain I'm not tired. At least to get to the end of the shift sometimes. I don't want to be falling asleep when I'm looking at a monitor and I got dopamine and Levophed drips running on a patient. I need to be alert. We harden ourselves against the cries of the patients undergoing painful procedures. Okay. You ever seen somebody have a chest tube put in yet? Yeah, okay. They're not all sleeping or intubated, right? It's like, it's not a good idea. We put aside our personal problems, leave the home life in the glove box when we walk into work. Okay. A lot of us, I don't know, maybe you, I know for me, I'd hide at work. That was my history before I even got into healthcare. I put myself in work, my work was my identity. Okay. Say breathe, Bret, yes. Get a drink of water. So the same technique we use to allow us to deny our own painful addiction. Okay. It's compounded by denial of family, friends, co-workers that may be ashamed that we have a problem. We're a nurse. We should not have a problem with addiction, gambling, sex addiction, meth, shopping, any of those things. We're perfect, right? We're looked as saintly. Reactions like ignoring or helping the addicted professional at work speaks volumes about the profession's ignorance of addiction. What that means is that people that cover up for other nurses instead of giving them the help they desperately need earlier. Okay. Next slide. Dr. LeClaire Bissell's profile, the chemically dependent nurse. Now, if this applies to you, you can raise your hand or not, but perform in the top 1/3 of their class. Earn or earning degrees beyond their basic training, held demanding and responsible jobs, were highly respected for excellent work, ambitious, achievement-oriented, normally started using drugs legally, whether it's cigarettes, alcohol, or in some states, marijuana. Used drugs in private, which really compounds our denial. Tended to use legal medications rather than street drugs. See people that go to the dentist or the doctor frequently, frequent sprained ankles and bones, and that broken ankle that hasn't healed in the last 7 years. I'm not saying they're not in pain. I'm saying opiates don't really work that great on chronic pain, according to current studies. Average age in the disease manifested at 40 years. Does that mean any of you are under 40 or off the hook? No, that's when it peaks and it really comes out and rears its ugly head, is about 40 years. Now, last one. No, all of these are past tense, indicating a lack in the belief of recovery. Because as we're going to talk at the end of this thing, most managers, doctors, and people see disease at the end of its run. Nurses that lose their jobs usually don't return to the place they were working at, so they don't get to see a recovered nurse. Do I look like a guy who was living in a porta potty 12 years ago in Venice Beach? I didn't think so. Probably the biggest drunk you will ever meet. Okay, next slide. So barriers to help. The health profession as a whole is very judgmental. Okay, we're not supposed to be judgmental of our patients, but I guarantee you, we are very judgmental. Who's got a report and had that look when they said, it kind of looked like you didn't know something when you're giving a report? Okay, the littlest things. I hope that's certain. I try to change it. I don't tolerate it, but we're very judgmental. The health profession has the idea that knowledge can fix the problem. And then there's fear of problems with your license. You don't want to reach out for help, because if you reach out for help, you get reported, you lose your job. Nobody wants to lose their license. So you hide in the closet, you do more drugs to deal with the stress about losing your license because you're using drugs. See the spiral? It's the same spiral. Whether it's shoes, cocaine, alcohol, playing the lotto, it's the same spiral. Acknowledging the problem is admitting loss of control, when the opposite is true. Surrendering to win is what's going to save your life. Lack of optimism about treatment by nursing management. Again, not many people get to see the successful recovered nurse, and I'm blessed to know hundreds of them. I get to do this talk with nursing students, and I get to talk with recovered nurses as well. Next slide. Okay, now the fun stuff. Had to go quick, I wanted to catch up. This is the important thing. We're talking about licensure a little while ago, and anybody who has anything on your record, you have to report that stuff, okay, when you get your licensure. Let's talk about enforcement and probation first. This is the criminal justice side of the Board of Registered Nursing. This is not the, we're going to take care of you side of registered nursing. Again, criminal justice. Okay, this is court, this is real, this is law enforcement. Somebody believes you're taking drugs, using drugs, coming to work drunk, otherwise under the influence, or not taking care of a mental health disorder like you should be, they can get a complaint. If they get the complaint, there'll be an investigation. If they find cause, they may take legal action against you, and if you're stealing, that actually goes to the local district attorney, not just the Board of Registered Nursing. So you get a double hit. Double jeopardy does exist. There are two different things. One's licensure, one is criminal. And then you have to do probation monitoring. And they write a written report, goes to the BRN review. If they find violations of the Nurse Practice Act, the case is forwarded to the Attorney General, who then will tell you you get to keep your license or not, or whether or not you get to do something about it to get it back later. So it could be revoked, it could be suspended, or it could be put inactive status while you do other things like probation. Has everybody read the Nurse Practice Act?
Yes.
Okay. ANA Code of Ethics. That'll give you a lot of clues on what's in the Nurse Practice Act. One of the beautiful things about the ANA Code of Ethics is it talks about we're supposed to help each other when we're in trouble, especially when it comes to chemical dependency or other issues, to get us back to healthy practice. That's what we want. Still a new world with that. Even after WeCare's been around since 1981, it's still a challenge. So again, probation, possible outcomes, revocation, suspension. You get to accept to voluntarily surrender your license, which is kind of a polite way of making you hand it over. It can be placed on license on probation, and you can be cited and fined. Get the next slide, please. So for probation, a compliance contract is written. You have to do a certain amount of inpatient residential treatment based on what they think your severity of illness is. I've never seen anybody do less than 30 days. And then you have to do about a 36-week intensive outpatient program, 36 session, sorry. Usually about 12 weeks, 3 times a week. And then a weekly aftercare following that. So we're already in about a year and a half now. Does that sound like a lot to do? Tell them how many people can't even get to this point. They just give up, they quit. Addiction's so powerful they can't even do this. So get it early. Earlier is better. Don't get them when they're too far gone. But they can be brought back. I'm living proof. A complaint will always be present on a professional record with the BRN. Does that mean you're never going to get hired again? No. Time doesn't completely heal all wounds, but it makes the scars enough that you can show what you have done. The same as when you put in for your licensure. If you have anything in your past, it's more about the 80-20 rule. Okay? It's 20% about what happened, 80% about what you have done about it and continue to do. You follow me? What are you doing for recovery moving forward with your life? Okay. That's what probation wants to help you get to. But again, it's the criminal justice side of the arm of the Board of Registered Nursing. When you complete, you get your license restored without restrictions. I'm going to talk more about this stuff because there's a little bit more info on the diversion side of these that would just be a duplicate, and I don't want to bore you. So successful completion, license is restored without restrictions. But again, the original complaint, when you go to your own website, sits there in this PDF telling the world, public, what you've done. So, or allegedly you've done. Next slide. So the diversion program is a different animal. Okay. You can self-report, but you have to request it. It's not automatically offered. Before I can get into this too much, I'm going to do a real quick one. Who thinks you can get thrown on probation for one DUI? I should see every hand in this room.
Yeah.
You think they can give you a DUI for having a bottle of beer sitting on your car in the driveway with the engine running? Yes. Okay. That's a moneymaker. I'm not knocking law enforcement, but that's what they are. Law enforcement. Okay. You need to watch yourself. You're getting into a profession where the Board of Registered Nursing in the state of California can dictate what you can do in your professional and private life. You go to Hawaii for a month and you have a joint on the first day and you come back and that's all you did and you stub your toe and you go down and you pee in a cup and it shows up as marijuana, that is a presence of drug and reportable. You got it? Serious business. Serious business. I cringe anymore when I hear nurses going, oh yeah, I went to the dentist and oh my tooth's hurt and I took a Vicodin. And it's like, you need to go. Go do admin or something, but not patient care. It's all bad. Serious business. So for the diversion program, what that means is not, we're going to teach you how to steal drugs. What that means is they're going to divert you from the criminal justice system into recovery. Okay? The diversion program is made up of people in recovery, whether there's a psychiatrist who's sitting on the committee, other members of the board, and people that volunteer and are appointed. So if that same complaint comes in, you can be self-referred or the board can be referred. So if somebody gets a complaint on them and it goes to the board for probation, if you're quick, you can call. I'll give you the number and you can ask to see if you can go into diversion. Of course, you have to want to get better. Okay, that's the key to this. It's about recovery, not avoiding jail time or avoiding your license. It's about wanting to do something different and be a healthy practicing person who hopefully can then be a happy, healthy practicing nurse again. You got it? Okay. So it's a 3 to 5 year program in diversion. Now, before you say probation sounds like a better deal, they run about the same time period. Probation may run longer sometimes. You have to do random drug testing, just like in probation, with a minimum of 18 times per year. And it costs you out of your pocket, even when you're not working, at $58 to $85 per pop. Okay? Diversion Evaluation Committee, it's a face-to-face meeting with 4 to 6 individuals, one member of the board, a psychiatrist, and your case manager, who would then look at you and see how you're doing based on your monthly reports, and we want to see every 3 months to 6 to 9 months to follow your progress. They have you go to 12-step meetings every single day for at least the first 3 to 6 months. That's not like 4 today and none tomorrow. It's like every single day, depending on what your reason for being there is. Or it's AA for alcoholism, Narcotics Anonymous for opiates or other drugs, along with, in addition to, nurse support group meetings weekly, 1 a week. We have 3 every week down at the Lincoln Glen Church here off Books and Avenue in Willow Glen. Tuesdays, we have 2. We have a 4 to 5:30 and a 5:30 to 7. And Wednesday morning, we have a 10 o'clock. You have to go to therapy, outpatient, inpatient. We talked about some of that rehab stuff already. You don't get to work for 3 to 6 months. You think employers like that? You're probably going to lose your job more often than not. Is that a good thing? You may not think so at the time, but it is. Because if you need this, you don't need to be thinking about work. You don't need to be thinking about the dog, just like nursing school. And whenever I do my bachelor's program, they told me, put away the vacuum, don't do any housework, don't do any cooking, and focus on your studies. Anybody here think nursing school is easy? No, nursing school is hard. Well, this is hard too. Okay. And addiction, if it's ruining your life, you need to really take a step back, and then another step back, and start over. And you can do it. Narcotic access restoration can vary depending on the nature of the offense. Typically, they don't want you even doing patient care to begin with for the first 6 months, and then narcotic access is usually limited. What you can do and give. There's worksite monitoring. Now, this isn't a babysitter following you around 24 hours, 7 days a week. This is just your job making a piece of paper with little bubbles on it saying you didn't work any doubles, you didn't work a bunch of overtime, you're not carrying narcotic keys, you're showing up to work on time, you don't look loaded, and those types of things. Okay? You can still do the functions of a registered nurse, depending on narcotic access, but that's what the worksite monitoring is. Now, a lot of employers aren't aware of that. As soon as they hear that, they don't even want to interview you. So, if you get in trouble, I'll give you the number to call. We'll give you some primers. You'll get them in nurse group 2. We'll tell you how to overcome that. There's naltrexone. Sometimes that's used, especially for the opiate addicted. I haven't seen it really used too much. But here's the difference. Upon completion, okay, the original complaint sitting out there on your BRN license number, but when you're done with diversion, it's gone. The original complaint is destroyed. All records are destroyed. Original complaint is gone. There's still a record hidden in the BRN, but we're not providing it to the public. So you get a clean slate. Now, if you mess up, early termination can happen, or you withdraw from diversion. Again, diversion is voluntary. You have to say you want to do it. So you don't have to be there, but if you pull yourself out, they can usually refer you back to the BRN, and that usually results in probation or worse. Most people I've seen that couldn't complete diversion got sent back to probation. And you don't get credit for time served, you get to start over. So, next slide. So on your application, we talked about we have to include all misdemeanors and felony convictions. Again, don't just make a list of that stuff. Tell them what happened, what you did about it, and what you're doing so it doesn't happen again. Whether it's driving too fast, or that one DUI you got, whatever it was, the drunk in public, when you were 16 and you got it expunged, it's not expunged from the Board of Registered Nursing. It's a government licensing agency. They see everything. If you lead it out, there's a question of your truthfulness that comes in, and that affects what they think of you as a professional, and they will not want to license you. It's already backed up enough, so give them all the information. And if you are in recovery already, document your meetings, document what you're doing, so you can send that to them as well. And letters of recommendation don't hurt. So, I had to do that because I didn't come into nursing clean and squeaky clean with a halo on my head. I had a packet when I sent my licensure application in. And they granted me one, and they've been one since 2007. All right. So even if Penal Code 1203.4 is an expungement, where if you got a DUI and 10 years later or 3 years later, whatever the time is after that, you want it off your record, you can apply to this and the judge can make it go away. Okay, it still sits on your DMV record, but when your employer logs in, he doesn't see it. The BRN does, because they're the government. Okay, just so you know what that is. You will have to submit fingerprints, so that's not just your local city area or county or California area. That goes across the Department of Justice website across the nation. So if you've ever been stopped, fined, or whatever, and printed, yeah, it's in there. Next slide. Oh, back up one. Page up. Okay, so the number at the bottom is for We Care, the 235-1178. I brought some flyers up here, and Sharon Lettman's business card up here, who started the We Care support group in 1981 after she was arrested at O'Connor Hospital. You can talk to her and get her story for yourselves, but similar to a lot of ours. So thank her for that. Next slide. Okay, Maximus is the diversion program contactor. That's the 800 number there. So there's 2 numbers to call if you get in trouble. You have to be a licensed registered nurse, okay, to participate in diversion. You can't be a nursing student and then get in trouble and then try to get in diversion. You already have to be licensed, okay? That's the little kicker. They're not going to come after, well, they won't license you if you have a problem that you're not dealing with. And then the diversion program manager is up to the 916 number. That's a wonderful lady up in Sacramento. And she'll get you in touch with the right people. Okay, next slide. So, We Care is a safe, supportive environment with meetings on a weekly basis, facilitated by healthcare professionals who have experience in chemical dependency. We didn't just read it from a book, we lived it too. Nonprofit corporation established in 1981, and we work with the BRN in the state of California. So people that come there, we report back and tell progress and how people are doing and that they're attending the meetings. And it's completely confidential, and nobody's attendance is reported unless we have to, and usually we get your written consent for that. So if you're going to be in diversion or probation, you sign a paper saying we can tell probation and diversion that you're there, which benefits you, so it's a good thing. And with that, I think I'm done. Did I make my time? Hey! Thank you so much.
So we're going to have a few questions.
Any questions?